Good morning. Surgical site infection is a massive problem. 38% of all nosocomial infections in surgical patients are surgical site infections. 4 to 16% of all nosocomial infections upon hospitalized patients are surgical site infections. 2 to 5% of operated patients will develop surgical site infections. Costs are obviously quite elevated. It is estimated up to $845 million per year in estimated costs from surgical site infection. Risk of death is 2 times higher. ICU admission is more likely. Home health care costs rise dramatically, and readmission is more likely. A surgical site infection is defined as purulent secretion, organism culture from the wounds, are classic signs of infection, and these are characterized both as incisional, superficial or deep, or organ space. They're defined within 4 weeks of the operation unless an implant is in place, whereas this will extend the definition for 1 year. Infection develops because of a number of factors: the inoculum of bacterium, the virulence of bacteria, and the microenvironment of the surgical site. As surgeons, we can affect perhaps the inoculum of bacteria and certainly the microenvironment of the surgical site. To review pertinent microbiology, gram-negative rods and facultative anaerobes, E. coli specifically, aerobic organisms, anaerobes with Bacteroides fragilis being a major player in infection, and gram-positive cocci. Certainly antibiotics do work. The quest to decrease surgical site infection, then defined as wound infection, really began in the 1960s. Bernard and Cole, in their paper, Prophylaxis of Surgical Infection, used penicillin G, chloramphenicol, and methicillin, looking at patients who had surgery on the GI tract, and they decreased wound infection from 27% to 8%. Nichols, in really a seminal work, using preoperative antibiotics following bowel prep, really led the charge. Interestingly, in the first paper from 1973, although there were 20 patients involved, 3 out of 10 had a wound infection without antibiotics, and there were no infections with, and the charge began. It led to the 70s with Goldring. They found that a bowel prep with oral antibiotics dramatically decreased the counts of coliforms and Bacteroides, but mechanical cleansing, importantly, alone did not reduce bacterial flora. So clearly, adding oral antibiotics had an effect on the bacterial load and on wound infection. Prospectivized randomized trial obviously followed quickly, and in 1977, Condon published this study where he found wound infection rates in the treatment group to be 9%, with 35% wound infection without antibiotics. So Baum, finally in 1981, after putting a lot of trials together, 36% infection rate in placebo, 22% in control. From this point on, he felt it was not appropriate to have a control group without antibiotics. Clearly, oral antibiotics work. With regard to timing of antibiotic, the classic and most important work to date is this by Klassen and Burke in New England Journal of Medicine. Almost 3,000 patients given intravenous antibiotics. If the antibiotics are administered before incision between 2 and 24 hours before the incision was made, 3.8% infection rate was seen. If the antibiotics were given within 2 hours of operation, a 0.6 infection rate. Parap given within 3 hours after the operation terminated, and then post-op after 3 hours. Each of these groups is independently different from each other, and PrEP was clearly the standard to which we should all aim. Aiming and achieving are 2 different things. Matushka, an American surgeon, found in their study of hospital patients, only 32% of patients received antibiotics within 1 hour. So we changed the responsibility of the administration of antibiotics to the anesthesiologist, and within the next year following the study, 88% of patients had the antibiotic administered within 1 hour, that golden period where blood levels would be high upon making the cut. Clearly, we should implement these changes in our practice. Route of administration, there's been a lot of work trying to define the optimal route. Copper from Newark University randomized patients all received bowel preps. However, their treatment group had antibiotics of cefoxitin. They had a 6.6% infection rate with oral and IV in combination, 18.3% without intravenous antibiotics. Clearly, intravenous antibiotics helped this group. Of course, it followed rapidly to see whether we could eliminate oral antibiotics at all. In Annals of Surgery, October of 1983, 19 patients were randomized, and infection rate did not vary between those receiving oral antibiotics and IV antibiotics. Obviously, you can see the very low infection rate. Prospective randomized trial, 2005, work is still continuing, and this group found that there was no difference in surgical site infection, but less nausea and vomiting in the patients who didn't take the oral antibiotics. When surveyed, members of the American Society of Colon and Rectal Surgery do believe that IV antibiotics and bowel prep are dogma. Oral antibiotics are still used frequently. Again, to show that work continues, 2007, 491 patients were randomized, and again, surgical site infection was equal with those groups receiving oral antibiotics or oral NIV or IV alone. Probably the best way to answer this was a prospective randomized, was a meta-analysis, and Song and Glennie performed a thoughtful one. They looked at surgical site infections across 147 trials involving 23,000 patients, and these were their conclusions. A single dose of antibiotics was as efficacious as long-term use. There was no convincing evidence to suggest that second or third generation cephalosporins were more efficacious than first generation in this indication. There was no additional benefit whether one used IV or IV plus oral, and this was over 6 trials.